me now?
Okay. I want to welcome everybody to the webinar. I'm Matt Emmons. I'm Medical Director of Quality Improvement at LA Care. And we're going to be talking today about member experience, really being able to improve member experience within the managed care setting. This is the first of two webinars that are actually the same. If any of your colleagues weren't able to attend this one, it'll be happening again in 2 weeks, correct? Okay. All right, so on the agenda, I'm going to do a quick intro, and then Matt Peritano is going to talk about, give us a refresher on CAHPS. Asal Sapasi, our QI director, will be talking about recommended interventions to improve member experience. And then we'll close up with Deborah Vanders talking about access and availability, which is a key component of member experience. So we are recording this webinar, and we will be posting it, so it'll be available for enduring use as a reference. You will get a copy of the PowerPoint after the webinar. And we will have, we can receive questions through the chat box function. We encourage you to go ahead and submit questions at any time you want so that we'll be able to address those and we won't get inundated at the end with a ton of questions. And there's also a survey at the end. We appreciate that if you complete that for us. One of the things I wanted to point out of why member experience is so critical for us as a health plan, our NCQA accreditation score, and this is for Medi-Cal, is made up of 3 components. The standards, which go back to when you were last accredited, and we have another site visit coming up this year. Your HEDIS scores, and those change every year. And then the CAHPS survey, which also change every year. If you look at the available points and our health plan points for CAHPS, you can see that it's not a good picture. The last 3 years it's actually been going down, went from 8 to 6 to 4. So and you can see that it's having a real impact on our accreditation score. So we as a health plan really have to do something about this. When you look at CAHPS, which we'll talk about, which are at the group level, there's a wide variation in the CAHPS scores. And in my mind, that emphasizes that the IPAs and the physician practices have a significant role in our overall, the overall member experience within our health plan. So we really need your help in this. Not to say that we don't have a lot of work to do on our own, and I just wanted you to be aware, I'm not going to go over this, but we realize we have a lot of improvement that we need to do for our own customer service, and that's both at the member level and at the provider level. There's a huge cross-functional project that is kicking off right now called Voice of the Customer. And it's going to be a long, involved project, but it's really going to be redoing the whole way we're able to serve our members and our providers with improved call routing, call tracking, self-help tools, a lot of different things to really be able to handle the volume of calls that we receive. So, and I hope as voice of the customer, I hope that at some point that you may very well have some an opportunity to provide some input into that process. So let's go ahead and we'll talk about CAHPS.
Thank you, Dr. Emmons. This is Matt Peritano. I'm the manager of Health Data Analytics. I was in QI up until April of this year. Patrick Cornett is the current QI staff who is going to be managing the CAHPS going forward. So he will be your contact for this going forward. So this is, again, a refresher. So CAHPS, we sampled it at the IPA level, so it's different from health plan CAHPS in a few different ways. We also require that individuals who are sampled have had at least one encounter in the last 6 months. And the scales are specifically designed so that they're measuring characteristics of the IPA that you can work on in quality improvement initiatives. And the last point here is that this is included CAHPS in both our pay for performance at the IPA level called LAP for P, and also in our value initiative for IPA performance, or the VIP.
So just to clarify, that includes membership and across groups, across plan partners. So this is all of LA Care as a whole, not just our LA Care Direct.
All Medi-Cal.
Yeah.
Yes.
Yeah.
So we conduct it every other year. Currently, there are 2 versions that we field, an adult and a child version, and we also separately sample satisfaction with PCPs and specialists. And these measures listed out are the measures that are included in the CAHPS survey. So this is just a sample of one of the summary reports that you get. There's a lot of reports. There's a lot of useful information that we provide to the IPAs after we field this survey. This is just at a very high summary level, summarizes each of the different composites that were listed on the previous slide. This is just showing you for one of those composites the overall rating of care, and it's separated out by overall rating of healthcare and overall rating of provider. This is the kind of display that you would see. The little black diamond shows you where you rank relative to your peers. This is an overall average for LA Care, so it's just smack dab in the middle of that distribution. And this is another sample of some of the quality improvement material that is provided in the reports that come out of CAHPS. These are the priority matrices. Basically what this is showing you is that it's trying to help you see what are the things that are really driving the satisfaction with overall healthcare. So on the y-axis here you have the overall rating of healthcare, and on the x-axis is the achievement score on each of these different composite CAHPS measures: doctor-patient interaction, office staff, care coordination, health promotion, and timely care and service. Everything that is to the right of this vertical line is above the 75th percentile, so 75% of groups perform at or below this line. So the goal here in reading this type of display is to identify those measures that you want to focus on, which would be in this upper left-hand quadrant, indicating that they are pretty highly correlated with the overall rating of healthcare, and also that you're below the 75th percentile, so there's some work that you can do on those. Anything that's above the 75th percentile, for the most part, you want to just maintain and sustain that level of performance. So that's all that I'm going to go into on CAHPS. If you have any questions, again, there's lots of material, and we are more than willing to go over the voluminous reports that we provide you. All right, and Sal will take the next part.
Good afternoon, everybody. So I'm going to speak a little bit about interventions that you can create around CAHPS using the reports that Matthew just pointed out. You should have gotten both a summary report and a long form report within the last year. We did send them out again within the last few weeks. If you haven't gotten them, or if we sent them to the wrong person, please go ahead and let us know. I want to start off by just saying very quickly that this is something that we're rather passionate about here. Member satisfaction is not only a matter of accreditation for us, but it has been tied into higher health rates. It's been tied to lower costs. This is something that is very much part of medicine now, and something that we hope to help shepherd in. So where to start is a big question, mostly given that it's a lot of questions, a lot of different things. Looking at those CAHPS scores, as Matthew just pointed out, will give you an idea of where to start. We always encourage you to have extra data. Do your own surveys. The highest performing groups have asked their own questions. We'll talk about a bit around rounding, and it's always important when creating goals to make sure you have timelines and make sure that you're looking at measurable goals. It makes it far easier to go through. So to start with, and Deborah will be talking quite a bit about appointments and scheduling and access, but these are part of what's called open access. It's a way of looking at appointments in a way that maximizes usage of patients. Happy patients are the patients who can go home the easiest. So a big part of this is ensuring the availability of the same-day appointments. We want to encourage you to be creative with these things, so prioritizing appointments, particularly following ER and inpatient discharges, educating your patients on after-hours urgent care services, and tracking referrals and recommended follow-up specialties is a big thing to do. You also want to establish protocols, so it's not this just general abstract idea that, sure, we'll get back to them as soon as we can, but have, again, measurable goals. We will reach all of our patients within 24 hours, for example. So going on with the strategies for timely access, you want to open up the schedules. A large amount of open slots has led to an incredible decrease in no-shows. We want to let you know that from our own experience, we just did a massive call campaign where we spoke to 27,000 people who had not been to the physician within the last year, and they almost all cited an inability to fit it into their schedule. So evening and Saturday appointments are huge. It's easy to start getting very in the weeds with appointment types. It is the easiest thing to do is to keep it wide, new patients, old patients, and we don't need to bring in patients for all the things that we've always brought them in. For example, follow-up visits for UTIs, or normal pap smears, things to that effect can be done through emailing and phone. And using appointment reminders, this is so old school, but just getting on the phone the day before or using your patient portals to send an email. Some practices use text messaging. All of these will help you see more patients who are happier, and it leads to satisfaction not only for the member but for the provider as well. Another one that we're quite intrigued with, another idea, is the idea of self-scheduling. Some practices have found a wonderful way of cutting back on costs and timing just by letting the patients schedule themselves. This is very much based on the idea of those minimum categories so that a patient can understand what they would want to do. And preventive screenings and services, we have this whole idea in medicine that preventative screenings are for the family practitioners. Anytime, or for the annual exam, anytime folks come in, go ahead and push those pap smears, those blood pressure costs. We all know that this will lead to much simplified medical decision-making in the future as well. Phone and voicemail practices, I realize we often don't think of the voicemail as an extension of our practice, but it very much is. It's often the first thing that members reach, and it's often the part of the office that the member has the most experience with. Ensuring automated phone triage processes at this point is vital. Minimizing the time configured to out of office is vital. We suggest staggering lunch times in order to make sure this happens. And make sure your after-hours messaging is compliant. Our regulatory bodies are very clear on what they expect. We'd like to, again, encourage you to return all voicemails within 1 business day. And if you don't mind, I'm just going to go ahead and plug a little bit of LA Care. We do have a cultural and linguistics department and a language line. You call this language line, we should be able to provide you interpretive services. So please, if this helps at all, use it. So I'd like to speak a little bit about rounding. This is something that is all over the literature. It's backed up by research as well as colloquially from different conferences and such, and our own experience. Rounding is the idea that administrators or leadership should go around the clinic and speak to the patients in order to ask them about various things that you're trying to push. So the first step here would be to determine an area of focus, whether you want to look at service or wait times, if you want to look at patient education rates. You want to, again, have measurable goals that, for example, speaking to 25% of all established patients, 100% of new patients. This is very much a site-specific thing. We do not in any way think that we know your patients better than you do. So please take these parameters and shape them for yourselves. You want to make sure that you have a way of communicating the information that you get This is, again, going to be specific to your clinic. If you guys like stand-up meetings, use those. If you're a newsletter kind of organization, go for it. You want to make sure you highlight the staff who are doing the best. There's always somebody in the clinic who is the one the patients love and go to. Make sure that they're recognized for it. And use this time to audit the behavior of your staff. Make sure your staff is doing what you as leadership expect. This is a very simple form. I just wanted to make sure you saw what I meant by rounding. Rounding doesn't have to be particularly complicated. Just who the patient was, what was working, what wasn't, who needs a little extra help. And this should not be punitive. Being punitive towards staff members will not make them treat patients better. Happy staff equals happy patients, as we like to say. So again, each site should have its own goals. Outcomes should be reviewed by people who are familiar with the site. And this shouldn't be like we're going to have a patient satisfaction week once a year. This is a thing that needs to be part of our lives as medical providers. You share your success stories. You make sure it's at every staff meeting. And rounding, as the doctors know, is a very old tradition of ways of talking about problems and issues and coming up with collaborative answers to those questions. Reviewing the very basics of customer service, knocking on doors, introducing yourself. We'll go into that a little bit more. You want to make sure this is part of the staff training, not only for new hires, but ongoing staff training, that this is something that you expect and set the stage for that. And there's a lot of research these days in the management world about pizza parties and how people do better when they are recognized, even if it's not with pay. So throw a pizza party and get that patient-loving clinician some love. I mentioned customer service standards. This is something that is, again, a national trend. Cornell, for example, sends all of its nurses over to hospitality training. These are the very basics. I know we don't like to think of our patients as customers, so if the word bothers you, ignore it. This is basic decency in general. Greet patients upon arrival. Let them know what the wait time is. If you're backed up, if something went awry, make sure you provide alternative options. Keep that communication going. Treat patients with respect. Treat your staff with respect. And this is something that we keep coming up in grievances and in speaking to members. Please don't reinforce negative impressions. When you speak badly about LA Care, about the IPAs, about Medi-Cal, this ends up affecting patient satisfaction. There's no other way to say it. And high standards. I think high standards are the way to go in life in general, especially around this. Perhaps you can't get to all patient calls within 24 hours, but make it a standard. Make it something to strive for. This is a mnemonic device that was created by the Studer Group. It's acknowledge, introduce, duration, explanation, and thank you. In essence, again, this is just how you yourself might want to be treated at a doctor's office. You want to acknowledge the patient by name, make eye contact, smile, greet folks, introduce yourself and your role. Give an idea of duration. We like to keep patients in the dark sometimes and not let them know because we don't want them to be irritated, but over and over it's been proven if you let them know and if you treat patients like adults, they will act like adults most likely. Explain exactly what you're doing, what to expect next. Make sure you're open to answering questions and let the patient know how to thank you or to contact you. And thanking, this is a new age. The years of the doctor being the only doctor in town are far gone. Thank the patient for coming to you because truly the patient has other choices. One of the things that we've come across in the literature is making sure that those expectations, the service expectations, are up somewhere public, both for your staff and for the members, in order to know what they can expect from you and to make sure that your staff knows exactly what's expected. This can be completely made for your own clinics, what you expect, and this particular place has a hallway expectations. Again, this is up to you. Colorful, bright, simple, that's the key to these. Providers, a lot of times we think providers, doctors are not the ones affecting member satisfaction, but they really are. Doctors and practitioners have become practitioners because they want to affect patients, and this is how you affect patients as far as satisfaction goes. Make sure you make eye contact. It's quite easy with EHRs to get sucked into your computer, but make sure you either use the computer as a tool to show the members things, and if you can't, explain why you can't or what you're doing. You want to set an agenda to get you through the appointment so there's no surprises for anyone. Listening and observing is forever important. Encouraging your patients to speak about why they've come in, their key concerns, and their health goals. We all know that encouraging patients to write down their concerns is a great way to go. And creating a connection, demonstrating empathy, it can be as simple as remembering someone's children's names, making sure that they're somewhere in your EHR to put in personal notes like those. These go a long way, and they lead to better health, honestly. At the end of the visit, make sure you summarize the treatment plan. Make sure the patient understands. We've all had the experience where the patient goes home and calls with a completely different idea or comes in next time with something that you did not intend them to do. And link those summaries to those goals that the patient told you about. Again, another plug for LA Care, our health education services. We did do some research not too long ago that showed that member satisfaction goes up when they recall being educated about health matters. This is, of course, counterintuitive. No, we all don't like nagging. So let us do it for you. We have health educators who are dietitians, we have mastery level health educators. They can do on-site group appointments, they can do telephonic consultations, and we have loads of materials for you to use in many different languages. Please reach out to us, and we will make sure that you get those materials. And resources. The idea that member satisfaction, patient satisfaction is important is becoming more and more of a norm. However, it is a new frontier. These are some of the things that we have found helpful. The California Quality Collaborative has some great ideas. The Suter Group is the originator of the AIDIT. We'd also like to encourage you to think about hiring a consultant to come in. Sometimes you need that extra eye from the outside. And if we can help you here at Quality Improvement in creating interventions, in tracking these things, please reach out to us. We would love to be as helpful as possible. And if you have any success stories, we'd love to hear that as well, and we'd be happy to share them so that patient satisfaction can become a norm. Thank you very much, and I'm going to hand it over to Ms. Deborah Manders.
Well, thank you, Sol. Hi, my name is Deborah Manders, and I work in LA Care's QI Accreditation Department, and I'm the lead project manager for Access to Care. As the others have stated before me, Access to Care is a major driver in member satisfaction. Access to Care comprises two areas that are measured for provider compliance. That's appointment availability and after-hours accessibility. Providers that are measured for appointment availability include all those listed: primary care providers, specialists, ancillary providers, and our behavioral health providers. Those measured for after-hours accessibility include all those listed except ancillary providers. We don't measure them for after-hours. So why is the member impacted by a lack of timely access to care? Besides the lower member satisfaction scores, there's an inability to receive preventative and/or chronic care services. There's the potential for an increase in preventable hospitalizations, and ultimately, it's potentially detrimental effects to the member's health and well-being. As many of you already know, timely access to care is a regulatory and accreditation requirement. In addition to DMHC standards, health plans are also required to comply with timely access to care requirements through contractual relationships with DHCS and CMS, and access, measurement, and reporting are also included in the NCQA standards. So these are not standards that LA Care is imposing. Actually, and some of the examples I'm going to give you is all health plans that operate in California have to abide by these, certainly DMHC standards. If you're going to deal with Medicare, you've got CMS standards. So this is not LA Care-centric. Whatever you do to help your network become compliant with access to care standards for us will affect their compliance rates for everybody. So how does LA Care measure access to care? We conduct an annual non-blinded telephonic survey of all LA Care providers. Those include those providers through our plan partners. It's the entire network of providers that see our members. Again, conducted annually by a contracted vendor. Appointment availability is surveyed during normal business hours, and after hours accessibility is surveyed outside of normal business hours, which includes evening, weekends, and holidays. Next slide. So here are, I'm just giving you some examples, but here's DMHC appointment access standards. Just to give you some context, DMHC sets forth specific appointment types that must be measured and reported annually to them. And here's a listing. So we have primary care providers, a routine appointment. A member should get an appointment within 10 business days of request. For an urgent matter, it would be within 48 hours of request. For specialty care providers, routine appointments within 15 business days. And for urgent, with no prior auth required, that patient should be seen within 48 hours. If prior auth is required, that patient should be seen within 96 hours of request. And then routine ancillary services, those appointments must be made within 15 business days of request. This slide here will give you some, it's not an exhaustive list, some of the behavioral health appointment standards. So for both MDs and non-MD behavioral health providers, for a routine visit, they need to be seen within 10 business days of request. For an urgent matter, for both MDs and non-MDs, within 48 hours of request. There are other standards. If the patient is more critical, that time frame is condensed. This is just an example. And then, for example, initial first prenatal service routine within 10 business days of request. We want to get those pregnant moms into the office. For after hours, LA Care requires that PCPs and specialists, including behavioral health providers or their designated on-call licensed practitioners, must be available to coordinate patient care beyond normal business hours. We all know that people have health care concerns, outside of the typical 8 to 5 time frame. So what this means is that the practitioner must have an automated system or a recording or a professional exchange staff that must provide the following information. So we've got 3 measures listed here, 2 access and 1 timeliness. These 3 measures comprise after hours accessibility. The first one is emergency instructions or a process for emergency calls. We most typically see those on most of the recordings. That's, if a member calls and is having severe chest pain or a medical emergency, the message informs the member, in that case, to call 911 or go to the nearest emergency room. The second access measure is there must be a process to reach the practitioner or a covering practitioner, whether that be leave your name and number and you'll receive a call, or maybe press prompt a digit and you will be directly connected to someone. But there must be a way that that member can seek medical advice from a clinician. The last measure is timeliness, and what that says is that the PCP, behavioral health provider, specialist, covering physician, or screening and triage clinicians must return a call after hours within 30 minutes. So I want to just talk a little bit about this. You must state this on if you have a recorded message, you must state that on the recorded message. This has been an area of confusion. So when we conduct the annual survey, our surveyor will call that number, call that provider's number. They'll get it, let's say they get a recorded message, proper emergency instructions. There's a mechanism to leave your name and number to receive a call back. But the message must also state that the member will receive a phone call back within 30 minutes. DMHC has said members need to know how to assess their medical needs. So if a member, because I get this question, well, why do they need you to state it? Because if you're someone who's got a medical condition and you're calling for medical advice, in order to understand what you may need to do, you need to know what that time frame is going to be. So, you know, if you can wait 30 minutes, you'll wait. If you know that a phone call is going to be made in 30 minutes, then you might wait. If you don't know that, or if it says the next business day, or if it says as soon as possible, your intent as a physician may be to return that call within 10 minutes, but the member doesn't know that. So DMHC requires that it be stated. It's the only way we can actually survey for the standard. And the other important thing is, again, you must be compliant in all three of these measures in order to be compliant with after-hours accessibility. So you may have proper emergency instructions. You may, on your message, state, if you need to speak with myself or the on-call physician, please leave your name and number. If you don't state that you will receive a return call within 30 minutes, you're non-compliant with after-hours accessibility as a whole. So it's really important that you understand that you have to be compliant in all three of these. Okay, so lastly, I want to focus on what can IPAs do to ensure that they have a compliant network. So over the last several years, my department has been working with actually the QI folks, that your IPAs and PPGs and your provider network folks. We've been working intimately with them over the last couple of years to determine what is the root cause for noncompliance. And once we have the root cause, what interventions have been successful in bringing practitioners into compliance. So we have a couple of suggestions here. These are recommendations. These that have been, proven to be successful at the IPA level. So include access language in your provider contract. When you're negotiating a contract with a provider, it needs to be known, these are the standards, this is what you'll be measured against. It's very important that you, when you're setting up, you've got your practice, that you're able to meet these access to care standards. The next step is, once you've contracted with the provider, include a review of the access and availability standards in your provider onboarding training. This supports the contract language. It supports the notion that you're actually training the physicians on what those standards are. And then the next step, which I think is crucial, and we found has been crucial with those PPGs who's been successful, is they audit new providers within 30 days to ensure compliance with the standards. So they don't wait until they're found by a health plan in an annual audit that they're non-compliant. They're actually ensuring that compliance within those first 30 days. So if there is an issue with compliance, you can nip it in the bud and you can deal with it right then and there. The next bullet, continue quarterly monitoring of the network and address non-compliance immediately. We instituted in October of 2015 a quarterly oversight and monitoring process. That's what I've been working with your QI and PR folks on. Your IPAs are required by LA Care to monitor practitioners that have been non-compliant in an annual survey quarterly until they are compliant. And I would encourage you to touch bases with those folks. They're doing a lot of great work, and we see the compliance numbers going up. And then the last thing is provide practitioners with solutions. Some of these practitioners are practicing medicine. They may not, may not be their forte. So give them some solutions. What has worked? And what we have, and you can go to the next couple of slides, but these last couple of slides are just resource material that we've developed here that's been very helpful. So on the screen, you see here Access to Care Quick Tips. We've laid out the appointment standards on it's double-sided cardstock. It's printed on cardstock. If you'd like these, we give these to our PPGs. They actually downstream them to the provider network so that they can have the office staff maybe put it up in their cubicle, because like I said, these standards are applicable to all health plans. And then the last slide is a helpful document. Asal talked about appointment availability interventions that you can do, some really great ones that she shared with you today. We also, in our conversations with the PPGs and working with them over these last several years, we have developed a listing of interventions also. I have on the slide here after-hours interventions at the physician office, for the answering service, for the provider office staff. So we will share everything that we can with you. The bottom line is we're here to support your efforts to maintain a compliant network, and you know, it's the old, what is it, Jerry Maguire saying, you know, help us help you. We're here to help you. We're here to support your efforts. We want to do everything we can to ensure that your network is compliant. That's it.
All right, so we're getting some, thank you, Debbie. We're getting some questions coming in. First off, I'd like to take a minute to remind you to take the survey that will pop up. We do look at those results and send out resources accordingly. So the first question is CAHPS sent to the members directly, or do they go through the IPAs first? CAHPS goes to the members directly. We do not go through the IPAs for that one. Another question is, how can we receive CAHPS reports? As clinics, the clinics at this point, we send them to the IPAs and ask that you go to your IPA for the clinic-specific reports. We're looking at this, but it's very much in the planning stages of.
Well, in the past, we didn't have reports for every clinic, depending on the group. That may be changing this year. We're looking into getting more granularity for some of our large groups that have, to get them more clinic-level reports.
Excellent. I believe Debbie had a question.
Yes, I have a question here. Let me read it. If you use an after-hours service in which callers access a medical provider, does the voicemail still need to state that the caller will be called back within 30 minutes? So my interpretation of this question is you're actually using an exchange staff for after hours. So the member would call, and they would either call another number or press a prompt, or maybe they would be directly connected to the exchange staff member. So I'll tell you how we survey the exchange staff. Our survey vendor will call, they'll follow the prompts, they'll get to the exchange staff member, then they will ask the questions. If a member calls with a medical emergency, what would you tell them? Is there a way for a member to reach the practitioner after hours? If the answer is yes, compliant for that. And then they'll ask the question, how long does it typically take for the clinician, who you're leaving the message for, to call back? If the exchange staff member says anything 30 minutes or less, you're considered compliant. If you reach the exchange staff member, you know, I think most of them want to do a good job, and I'm pretty sure that most practitioners, if they get an urgent phone call, they're going to be calling it back within 30 minutes. They might call back within 10 minutes. That's why we have to, the exchange staff member can't say ASAP or within 1 business day. They can say 10 minutes. Typically it takes 10 minutes, 15 minutes. Anything up to 30 minutes, you're good, you're compliant. So that's how that would be surveyed. If you get connected to the exchange staff and whoever picks up the phone, the survey vendor is going to ask those questions, but when they get to how do you reach a clinician, she says, well, I can directly connect you right now. You're good. You don't have to worry about the callback because there is no callback. That member is being transferred to that clinician directly. So it's only when the member has to wait for a return phone call that you have to state either on your recorded message that it'll be returned within 30 minutes, or the exchange staff member has to know that and answer the question accordingly.
Okay, we have a question here on how can providers speed up the referral process for urgent cases. You know, these are standards for these are standards that are set by our regulated bodies. There's going to be cases where it may require more, less of a timeline to address an individual patient need. So that's something you really would just need to work through with the IPA or with the specialist, and do everything you can to try to address anything that may be even more urgent than a typical urgent care standard time frame. The other thing I was going to mention on the rounding aspect for member experience is that either rounding or huddles can be both prospective and retrospective. I know some groups actually will go over the schedule at the beginning of the day and anticipate patient needs. So if they see somebody's coming in with a URI, but, oh, she's also due for a mammogram, let's make sure we take care of that. Or if they say, oh, she missed her last appointment and this wasn't addressed then. So that really just trying to anticipate before how you might be able to better meet those member needs.
And we also have a question about referring to health ed. So you can either go to llac.org, to our website, or you can go ahead and email us at quality@lacare.org, and we'll make sure to connect you. There is a form on the website, though, at lacare.org, that will have that as well. And there's, I believe, a question.
I have a question, too.
Oh, here. Debbie?
Yes. Okay, next question here. Do you audit every provider for after-hours voicemail compliance? The answer is yes, we do. We happen to be a health plan that audits our entire network. We audit, like I said, if you're a PCP, you're a specialist, or you're a behavioral health provider, you will be audited. The second part of that question is, what does the survey staff do when they reach voicemail? So what they're going to do is they're going to call the phone numbers that we have in our database. If they reach a voicemail, hi, this is Dr. Smith's office, they need to hear the recording. So if you have a medical emergency, please hang up and dial 911 or go to your nearest emergency room. If the surveyor hears that, they mark you compliant for that measure. Then they will listen to the recorded message to see if the member has a way to connect with the practitioner or the on-call covering physician or clinical staff. If there is a way, let's say it says, leave your name and number if you need to speak with your health care provider immediately, that would be considered compliant with a mechanism to reach a provider or clinician. The last piece, that timeliness piece, the message must say, you know, it says, if you need to reach the clinician immediately, please leave your name and number. The timeliness piece of that will say, and your call will be returned within 30 minutes. That will get you the compliance for the timeliness piece. These are great questions. Thank you.
Yeah. My favorite question so far is, can we use your slides to share with providers in Orange County? We like to encourage you to go through CalOptima or whoever your provider is in Orange County. However, we'd be delighted if you shared our slides with whoever you found appropriate in general. We all done? All right, thank you so very much. Again, we're going to do this whole thing again, get the same group of people together in about 2 weeks. It will be the same material. If you'd like to go over it again, come again, but please send your friends and colleagues. Happy New Year to everyone, and thank you.
Thanks a lot.